don't know if it was a challenge or a punishment, but for you or for me, but we'll try to do the best as we can. Of course, the depth of the two topics might not be the one that necessarily I wish I could have given you in an hour, but we'll see if we can get some discussion started at the very least. So I have no disclosures for you, and this is, we'll start with brain death. This is just a quick historical rundown on what the progress has been made in the definition of brain death. First of all, we need to be aware that regardless of the definition that we have been worked on in the last few decades, brain death has been described by observation since the Middle Ages. There were a lot of description. This one is the most famously quoted, is the one that described how Moses, I don't think I can pronounce his name correctly, but a rabbi described it how spasmodic jerk of a body without a head were not enough to define life, because there was no central control. That a body can move, but that doesn't mean that the body is alive, lacking the central control. And then the first definition in France with the coma dépassé, beyond coma, the first definition of reversible coma. So people that slip into this comatose state, there is no regain of consciousness, and the only mean that they have to breathe is because of mechanical ventilation. So you noted that here that the technology comes in and start raising the question of what is a comatose state if spontaneous respiration cannot be maintained. Then the first transplant come in. So A, the advent of mechanical ventilation, and B, the first transplant from donors that have severe cranial cervical injuries and were deemed by the physician not in a irreversible comatose state. However, a uniform definition was not there yet. So we're in the 50s, 60s, transplant mechanical ventilation, and as you can see, the necessity to come up with the definition, a description of this condition that's been recognized but not yet unanimously accepted or at least defined, comes up with the famous report from Harvard that starts to define from a medical standpoint brain death. And then soon thereafter, the legal aspect comes up, and in the 80s, so 10 years or so later, the President Commissions is created and assigned the task of defining death in the setting of irreversible brain injury, and that's the report that you see there. In 2009, interesting enough, there is a second task from the President given to the Council of Bioethics that writes a white paper introducing the definition of total brain failure as the most accepted definition of brain death, or at least the more, from a bioethics standpoint, accepted definition of brain death as a reversible cessation of brain function. And these are the documents that over the years we have developed and we are using now as point of references. This is probably the most important slide. If you need to bring home one thing that can help you and helps me as physicians, is having clear in your mind in every single patient and you will have that you encounter, have clear in mind that this has happened, that this has already happened. And by this I mean exactly what that picture described, that there was a major destructive brain injury, and you have to be clear with your mind and your physician skill that that happened, that progressively probably caused a loss of the complete loss of brainstem function, and you see those arrows start from the midbrain, go to the pons, all the way to the medulla, that caused breathing to stop, hemodynamic instability, and without the support of the mechanical ventilation, eventually the hearts will stop. Okay. So one of the premises that I always insist the most on, which might seem intuitive, but it is not always the case as you start dealing with this complicated case, is the neuroimaging brain death. So hopefully you will always have some sort of neuroimaging, most commonly a head CT, that shows you that devastating brain process, okay? And some guidelines go all the way to say that if you have repeat scan that don't convince you that there was a devastating brain injury, that should put you, at least should make you pause before you proceed into the brain depth examination. So let's look into this, and I'm just going to work with you guys just to keep you interactive and just reason together. So I don't know if somebody wants to volunteer and fill in this box, but let's say, I don't know, Amit, if you see that scan, okay, the patient comes up to you and has that scan. Let's say that, what would you say, if you have to guess something, what can cause that? Well, first of all, if you remember anything from the month with us, how would you describe that at CT?
Vasogenic edema with loss of gray white.
Right, so you lose the gray white, everything looks dark, and when we see dark in a head CT, we call it hypodense. It's pretty symmetric, so it's something that globally causes a loss of blood flow or loss of oxygen first and then blood flow eventually, and is both hemispheres, the brainstem, so a pretty devastating brain injury, okay? So this is what happens, the scan what happens. How is the patient behaving at this point? The first, how is the patient fighting? How is hemodynamically or physiologically behaving after this is happening, or has this is happening, I would say more appropriately. Are they hemodynamically stable and you can walk away from them?
Depressed level of consciousness, for sure.
Sure, definitely. So they are in a coma. They're probably intubated. If not, you better hurry. How about their blood pressure? What is their blood pressure in the first few minutes and that this is happening?
Probably elevated.
Elevated. Why? That's okay. That's okay. What is their intracranial pressure at this point? Any guess? Any number? 5 or 35 or 55? So how is that edema behaving with it? How is the brain starting to fighting that?
To raise blood pressure.
Right, so the brain, the body is trying to do everything that they can to defend their CPP, right? So you're probably having a blood pressure that's sky high at this point. How much labetalol can the nurse give him, Mark? Because that's the next thing that's going to happen. Your nurse is going to come and say, can I give him labetalol? How much? 10, 5, 20? It's 200. We don't let the blood pressure go to 200. It's bad for the brain.
I think in this situation, you want to preserve blood flow to normal brain tissue if you can. I mean, this looks devastating, but
yeah,
you want to maintain a higher blood pressure, so you don't want to reduce it.
Yeah.
Aggressively.
Yeah, and I'm bringing up this example so only to tell you that in this situation is where you stop, okay? Because you know that the next box is going to be, what's going to happen next in the next box? Anybody? So we are hypertensive, we are trying to protect our CPP. Eventually that is not going to work, unfortunately, because that skull is not being opened up, so there is a limit. So what's the next thing that's going to happen? That adrenergic sympathetic response eventually is going to stop, and you actually are going to become hypotensive, right? And there is another piece that, so you don't want to necessarily push that forward more than what you know is going to happen, and you know that the hypertension is going to be transient. So you most of the time have to leave him alone. What is the other piece that it might happen at this point as that pressure happens in the physiology of brain death? What's going to happen? What is another clinical observation that you do? And this time you probably want to do something if you want to, unless you want to get into trouble later on. So as that pressure compresses the midline structure, your pituitary gets compressed too, right? So you go into your DI. So the patient goes from hypertensive to start having an increased urine output. That, together with the lack of adrenergic surge, makes you in the next box, that is hypovolemia, if you haven't looked at that early on, and hypotension, right? So those are the things that you will chase soon after. That's why sometimes you just want to watch that hypertensive moment. And the last, as we said before, is the last lack of respiratory drive. So if your vent was for whatever reason on a spontaneous mode of ventilation, you want to make sure that you fix that before it becomes an issue later on. Once that happened, once that devastating brain injury has happened, and you have proof of that, that you have imaging and the clinical history that convinces you that that's the case, that's where your brain bath examination comes into place. There are some prerequisites that more or less we went over: the coma, the neuroimaging, the no spontaneous respirations, your systolic blood pressure greater than 100, your core temperature has to be maintained at 36 or above. You want to document the absence of any severe metabolic derangement, and we'll look into that. So once you meet all those criteria, here we go with the part of the neuroexamination. And if you follow this graph, and we are going longitudinally, caudal rostral from in our brainstem, starting with pupils, okay, and you've seen this. We're not going to go more than in that. And then you do your cranial nerves, your oculomotor, your oculocephalic reflexes, your vestibular reflexes with your head turning, doll's eyes, with the caloric, and then the caloric testing, your corneals, and then you want to test both 9 and 10 with your gag reflex and your cough reflex, okay? These checklists are available, and now we have an Epic Note. My suggestion is have some sort of checklist for yourself. There are apps. There is the form that the nurse brings. I usually always use either the form, unless you have your Epic Note pulled up, just to make sure you're consistent. Because in those moments, there are a lot of things that pulls you away and might not help you being systematic about it. A couple of notes that I want to make on the checklist of the on the cranial nerves examination. When you do oculocephalics, the spine has to be cleared, okay? We had more than one case where we're ready to go and there was a history of trauma that actually was the cause of the brain injury, but the collar had not been cleared and nobody had done C-spine x-ray to at least prove there were no major injuries. So think about that in advance. And then when you do your caloric, your oculovestibular reflex examination, make sure you can see the tympanic membrane. These are details, but you want to be accurate. You want to be testing something that physiologically you know how it's supposed to work. So look at the ears, making sure you can see the tympanic membrane ahead of time. And then I often get that question, how long do you wait? So you squirt all the water, you wait up to a minute, okay? You should not see any movement whatsoever, left or right, nothing. You should not see, don't get confused what I'm expecting, so you should see nothing at all, okay? And then wait a couple minutes and then repeat the test on the other side, okay? And then I get questions about the central noxious stimuli. When you are trying to provoke pain, you need to provoke pain at the central level, okay? Not because you don't want to facilitate spinal reflexes that can be confounding, and it's not what you're looking for. So central pressure, any type of central pain is preferred, like, and you have your orbital, you have a couple of choices, your TMJ pressure, your supraorbital ridge pressure, the trapezius squeeze. Sternal rub is not that it's contraindicated as long as what you're looking for is a central pain response. I prefer not to do it because again, especially if somebody is watching you and they don't know exactly what you're doing, you have a higher risk to develop spinal reflexes, but it's not that you should not do it. You should know what to look for when you provoke when you apply a noxious stimulus, okay? Those, I think, are the things that I see more often during the examination per se, generating questions. And then we go to what is the kind of the last final piece, the apnea test. More, which in truth, the only thing it means is testing the fact that in response to an increase of CO2, the brainstem does not generate a spontaneous respiration, okay? You don't want to see them breathing, but what you're really trying to do is, demonstrate is that the CO2 rises appropriately and the brainstem rises appropriately in the CSF. The CSF has a higher level of CO2, bathe your brainstem, and that is not enough to start the central breathing at the brainstem level. Okay, I think most commonly here we all have learned to disconnect the patient from the ventilator and apply enough oxygen at that point via 6-liter cannula down at carina. There is some institutions don't require that, I think is easier because you avoid any triggers. You know, ventilator can have secret triggers that no matter you try cannot be completely removed, and that helps that for simplicity. So disconnect the patient from the ventilator, apply the oxygen. Yes?
So we have a new system here. So those who've done a branded apnea test in the last 12 months will recognize it. So we actually have a maple smooth continuous flow and a beat valve that's hooked up to the patient. So you can actually see the insufflation of the maple smooth itself. Okay, sorry.
So what do you do? What do you do if you actually, like, that is becoming standard of care, is available for everybody, but applies specifically for your patient, which is the majority of the patient, especially in the MICU, I would say, that have some sort of respiratory condition for which you hesitate in pulling away that positive pressure that the vent is generating with the within the circuit of your ventilator. So again, as Dr. Bonham said, this is easily applicable with the maple or with the ambu bag, as long as you have a CPAP valve, can deliver up to, there are reports where an apnea test has been safely done with up to 20 centimeters of water pressure through this circuit. So do not hesitate to use it. We pretty much tried to test it and we like it. The other thing that the bag gives you the visual hint of seeing if a breath is taken, so that helps also your observation during those 8 to 10 minutes of the apnea test. So feel free to use it. It's there for the cases where there is refractory, where hypoxia, or you're worried about dropping deodorizing in the lungs by disconnecting and taking away the PEEP, but can be used in any case just to facilitate the apnea test and safely disconnect the patient from the vent. Don't forget to put the cannula, of course, through the ET2. And then I think the other special circumstance where Dr. Bonham definitely can speak better than me is the ECMO patient. Well, we have enough like CVICU staff here, but this has been done safely in ECMO patient, both increasing the CO2 content of the circuit or decreasing the gas sweep to allow CO2 to be built up. And other than those two maneuvers, the apnea test is done the same way. Disconnect the patient from the vent, you apply your positive pressure that is needed, you either decrease the sweep or you give the patient enough CO2 to document that the CO2 rises, but your brainstem is not reacting to it. Any?
Yeah, we just decrease our sweep here.
Yeah. All right, drugs and brain death. So this is another thing that sometimes creates some problems. Be mindful of the drugs that you used before and their half-life. You don't have to learn all of this, they are available, but be mindful that some of the drugs, especially phenobarbital is the one that we fear probably the most, but Valium can do the same, amitriptyline, especially in cases where the ingestion of the drug was deemed a possible cause of the brain injury that has occurred. And then be mindful also that the hypothermia will slow all those metabolism down in a way that sometimes is unpredictable. So use your judgment in the safety of the time frame that you let that you use to be sure that these are not confining your mind. On the other hand, I have to say that especially when it comes to the absence of severe electrolyte acid and base endocrine disturbances, again, this should be documented, but your judgment applies here too. In the neuro ICU, several times we declared people bring that have an increased sodium level, more than what is physiologically accepted sometimes, because that was a therapy that we apply to the patient, and it's not reasonable to wait sometimes for the sodium, or it's not necessarily, in my opinion, to wait for the sodium to go from 155 to 145 because in your clinician opinion, that has nothing to do with the initial cause of the devastating brain injury. But if you do so, please document which drug was given and why that sodium was raised in which circumstances. So there are no absolute values here. Again, use your judgment. Going back to that first slide, what is causing the brain death at this point? Brain death.
Is 100 hours enough? I think you've had a case in NICU when I was in NSICU that we had to wait for a week and then patients are moving and stuff.
Do you have a cutoff that you use? No. I don't think I have a fixed answer there. unless your level goes to less than 10 or 20. Yeah. So last part, what if the apnea test cannot be performed, or there is an issue with the reliability of one of the other tests? The most common that happens in our ICU, there's been some craniofacial injuries for which we don't have any way to test oculocephalic or vestibulocephalic reflexes. That's where ancillary tests come into play. Some institutions have them, especially in Europe, have them mandatory. That's not the case in the United States, especially as detailed by the AN guideline from 2010, which everything I'm saying actually refers to. Which ancillary tests might vary depending on the institution. We recently had a faculty member that came along and had a complete way to different approach in as far as which test to use. I guess that number one at UC remains the nuclear medicine test, where you actually use the isotope, inject, and you prove that there is no uptake, as this is called the hot nose sign or the empty hollow brain sign. I think our nuclear medicine department does a pretty good job in providing the service, but what you have to be mindful of is the timing. It takes a little bit to acquire the sequences, so you have to plan that this is a test that's going to take 3-4 hours, and of course requires the ability to travel. Second, in my mind, at UC, both a second level or your cerebral angio, so still required to travel, still at the flow study, and what you document is actually you have bilateral, so you need to inject all the vessels, 4 vessels. You have bilateral absence of intracranial flow and presence of extracranial flow. So you make sure that you document that there is flow in the carotids up to the cranial cervical junction. Downside, contrast, the need to travel, and the fact that you need an angiography, you need a neuro IR attending to be available for this, which is not necessarily something you can acquire anytime, any day, because they have call scheduled for other procedures. And there is only 1 or 2 angio suite working at the moment. 2, 1, 2. Okay. And then EEG. EEG is possible at UC. However, the biggest mistake we make is to think that the flat line that we see if the patient was already on EEG represents an adequate proof of brain death. There are specific settings that the machine has to be set for. The attending needs to be notified, and the tech that placed the electrode needs to be notified. And sometimes the placement of the electrode that has been done for your EEG monitoring is not the same. So if you respect all those criteria, so if you have a tech available, tech notified, the leads are placed in the correct position as per brain death criteria, and the attending is aware, this is a possible test you can use. But do not think that you can use your normal EEG monitoring as your confirmatory test without the premises that I just made. And then what we don't use. Transcranial Doppler are still used. We don't use them simply because, and the way transclub is another flow study. As you can see, that what you prove is kind of the presence of a small, brief systolic peak, or the presence of reverse flow. So this should be a systolic MCA flow, but you see just a little peak, and then the flow is retrograde. Okay. We don't do it here simply because none of the people that provide transcranial Dopplers, me and Dr. Flaherty at the moment, are certified for doing this, and we are not regularly available for this type of test on an emergent, urgent base needed as brain death requires at times. And CTA angiogram is not currently approved in our UCMC protocol. There are a lot of papers out there describing that CTA angiograms are getting better and better, and the sensitivity and specificity are improving. Again, some centers in the United States use it, but that's not currently approved by our brain death protocol. Movement after brain death. This is a very disturbing thing for our families and for our staff nurses. nursing staff. So you have to be very certain about this topic. As we all know, spinal reflexes are possible in brain death. There are a couple here I was going to show you just to give you a, this was not me, this was published, flipped, I have no idea why, but just try to be creative and imagine that I'm trying to see it the right way. So you see the opening of the toes, and they are eliciting it, but the reason why they're documenting this is that this can occur with patient turning. See that? I hope you can appreciate it as they did. Those are opening up. And the other one that actually was reported as having caused some, is this one. So this actually was reported recently because it stopped the surgeons from explanting organs, because the nurses were noticing that this little bird unfortunately seemed to be grabbing things. So surgery was actually postponed, the patient was brought back, and they documented this thumb-up sign was actually just a spinal reflex. So those are possible. Sometimes during the apnea test become even more visible. The feature that should help you are that often are provoked, and the same stimulus that you apply produce the same movement. They're usually slow. Both of them you saw was very slow, and they are stereotyped. They happen in the same shape and form as you repeat the stimulus. And then they are usually consistent with a synchronized decorticated disturbance response. It's not often that you see symmetrically happening on both sides, okay? So I sometimes, if I saw that happening before and the family is there during the brainstem examination, I warn them about spinal reflex. I say it out loud. There are some movement of the limbs that are possible. Those are spinal reflexes. Those are not mediated by the brain. I say it to avoid concern, even if they are just walking in and out. One other thing I've noticed that can distress families is that if the patient is young, sometimes you see their heart beating can transmit vibration to the abdomen, and that can be confused as a respiration. So I pointed out right away at the beginning. See, the heart is beating. That is transmitting some vibration to the abdomen. You might see during that. That's not the breath. The breath needed to have different, and I explain things as we go to avoid, and I do that with newer nurses sometimes because this is still rare to be seen. How to communicate brain death. One thing here, I stole this from a trauma surgeon, a shock trauma, like the 3-step approach. Just make sure that, first of all, you do the same thing you did to yourself. You have established that there was a devastating brain injury, there is a non-survivable brain injury. Say that out loud and let the family understand that, okay? And that's why I put that pause there. And I'm not talking about hours, I'm not talking about minutes, but just make sure in the relationship with your family that that has been acknowledged. And sometimes more than one family member needs to acknowledge that. And I try to do my best to make sure that every party, every loved one that is there that has the time to understand that. And feel free to use scans. At CT sometimes are very descriptive when, especially in those cases, to let them understand what we mean by devastating brain injury and survivable brain injury. And then be open about the fact that you need to do an exam to confirm the brain death. You can use, these are some sentences that have been used or described, like there is no sign of brain function left, we will confirm it with some tests. Be open about what is going to happen. And then the next step, there are some option of describe that there are some option of after brain death, and there is going to be a social work or another team that comes to discuss that with you. You might come from different centers, but this is done slightly different. At UC, we do not bring up as physician. We do not bring up brain death with families. There are several papers describing, we don't bring up organ donation with families, I'm sorry. There are several papers describing that actually helps the organ donation process one way or the other, dividing who is the team that was taking care of your loved one when they were alive, and the next step is not dealt by us. If they bring it up, I would just say I usually support their good intention. I say that out loud, and then I still refer to the Life Center team that should be by at that point to bring up the details of the further care. Okay. From the Life Center standpoint, anything else? Okay. So I was a little saddened by seeing that there's still, not saddened, but as in kind of this at least made me pause, the fact that when you Google it, as you all do, or I think I do, the topic that you are about doing a talk on, brain death is still on the newspapers, and you probably heard about that girl that was in California, now is New Jersey, and she was declared brain death in California, but she's on a vent in New Jersey now. And you just, I think you have to be aware there are some challenges. As much as we, as a physician, I accept that as, again, an irreversible brain injury that leads to an unsurvivable condition. There is variability across the U.S. Again, be mindful that the New York State required the physician to consider accommodating families who, because of moral or religion grounds, desire the maintenance of mechanical ventilation. There are some religious communities that don't accept the concept of brain death. And then there's variability across the world. It's very interesting seeing the debate in the literature that is going on in Europe and how there, despite we think we have unifying guidelines, at least from a clinical standpoint for the United States, every state, every place has different guidelines. And then, as you probably have already seen in your training, the United States leads the states which have their own, which actually let the institution decide their brain death policy, which can cause slightly difference in the way the brain death protocol is applied in different institutions across, again, the same state and definitely across the United States, which don't help, in my opinion, with these challenges. Any questions? Any difficult case that didn't fit this before we switch gears and we start talking about ischemic stroke? Okay, then let's do that in the sake of time. So it's impossible to talk about ischemic stroke in 30 minutes. On the other hand, I thought after I deal with brain death, it is a topic so charged of legal, philosophical, and religious challenges. This should be easy. This is bread and butter for you guys. But then I thought about a couple of cases that made me realize this might be a little more challenging for us intensivists than what we think. This is both. This is a case that really happened. Truly happened a couple of years ago. This is a 54-year-old woman with no past medical history. She's found down by her husband at home. She was seen normal at 10 a.m. Husband found her on the couch. There is some evidence on the floor. I think he was telling the story that he saw tea and a warm pad. So he had the feeling that she was not feeling well, that she prepared stuff for herself because she was not feeling well. That's what he found at home. And then she ends up in our ED. She's unresponsive. Her white count is 20. She's hypotensive, her lactate is 4. She gets intubated. Her CT is normal, so she's starting on pressors, and she's admitted to our medical ICU with sepsis. Any problem with this? Brian, any problem with this case? Any problem with her head CT?
It looks to me that maybe there is some asymmetry that
yeah, this is what it's pointing out. There is some asymmetry. She's a little tilted there, so it's hard to tell, but there is some more, maybe here the white gray, you know. Which vessel? That vessel, right? That one? The ambassador ACA, yeah. So this is subtle, right? This is subtle, but unfortunately, what happened is that at 1 a.m. neuro gets called because this lady is not waking up. She's septic and sympathetic, rightly so they want to put her on EEG. The neuroresident comes by and sees this EEG. What's wrong there, Mohammed? She's not seizing, I promise you. It's acute ischemic stroke talk. She's blinking. So really, the resident at that moment, where it's like, wait, she's blinking, okay? So the patient is actually following command via blinking. The patient is locked in. Goes to neuro-IR, they get consulted at 6 a.m., but the patient did not improve, and this was her MRI or a similar one. I don't think it was the same case I could find. But she had a vascular occlusion, probably that why she vomiting, or maybe she was vomiting, she dissected one of her vertebrae, and that caused this to happen. So another case, this is a 42-year-old woman. She's bipolar, she's schizoaffective, she is on lithium and lamotrigine, non-compliance. Everybody documented that in the chart extensively. She has some bloody emesis, and so she gets admitted. She's a little hypotensive, her hemoglobin is 8. The workup is negative, but she's non-cooperative, she's talking nonsense. Psych consult get called. They see that her lithium and lamotrigine were undetected, so probably she's out of range with her psych disease, and that's why she's so odd. She gets accepted by psych. And then the psych, by the time she goes to deaconess, she's actually neglecting one side, she's getting drowsier, she got a head stat SCT, and she has a left MCA stroke. That needs a micrectomy the next day. That's not her vessel because I couldn't find it, but that's her carotid shows a dissection. So this is where cases that, as I thought about, you guys know everything about stroke, but yet people have issues with misdiagnosed strokes in our hospital, in our ICUs, our included, several times, because it's not as easy as we think. 5 to 15% of strokes happen in hospital, and they are all, by every report, associated with delayed therapy, increased mortality, and worse outcomes. So at least we'll try to concentrate on those today. Try to see if we can help each other be better at this. So let's walk through a case to keep you engaged as much as I can. Let's say that this is your case today as you walk away. There is a 65-year-old woman. She's hypertensive. She has hyperlipidemia. She was a smoker. She was admitted with chest pain on the 6th floor somewhere, and she's found by her bedside nurse to be aphasic, drowsy with the new facial droop. And a rapid response is called, and you are the fellow of the day in charge of the Code Blue team. What do you do? What do you do? I'm not going to call name, but you. Karen, what do you do?
I'm going to try to assess how drowsy she is.
Yeah.
If she's protecting her airway, and I'm going to get a SCT.
Okay. Okay, you can get an SCT. What else? What other people want to do? You're there. You're in 6. I really want you to think about this is your next patient as you walk out of here. You got a head CT. Yes.
Considering alternative diagnosis as well, so that we check
One finger stick, yeah. What else you do? Yes. So this is your checklist, or at least the checklist. If I missed something, please tell me. But in my mind, you need to do all these things at the same time, because you can get the head CT, but without the stroke team, you cannot give TPA in this hospital, right? So you need to call, as you think about stroke, get somebody on the pager, say, page that you see stroke team. At the same time, as Brian pointed out, you want a finger stick, you want to make sure their blood pressure is within the range for TPA if that's what's going to happen. You need a working ID. You need this lasting normal time, without which the stroke team will not give you their full attention, because they need to know that before they get operative. You need possibly an NIH stroke scale. Sounds complicated, but there are apps everywhere. It's been shown can be done in 5 minutes. Just pull up your phone and try your best. You want to call pharmacy, because they still have TPA, as much as I told you that the stroke team will bring it for you. In truth, your critical care pharmacy is probably the fastest person to get to TPA at the bedside, because you're probably not going to go anywhere after you have CT when you have to make that decision. And you want a neurocritical care or a neurologist. I put there neurocritical care because we like to be helpful, but whoever has a way to communicate and help you through the process, because you're going to be transferring the patient, doing other stuff. The stroke team does not live at UC. That's something that not everybody knows. They could be at Mercy, or at Good Sam, treating another patient at the moment. So if you have a neuro person that could be at bedside and be your ally in treating this patient, that's be helpful. So All those things need to happen. There is not the one and like a priority line. This all have to happen as you coordinate your code team. TPA contraindication, you all know the new one. I was just the classic one. Sorry, I was just going to point out that recently the American Heart Association reviewed some of these and split them in relatively exclusion criteria, and these are probably the most relevant. These are the rules that we violate the most, if you want to put it that way. When we are no longer on stroke call, but when Dr. Bonham or Brian are on stroke call, or Kyle. The surgery piece, we violate that often depending on the surgery. If they just had a toenail removed, that doesn't count, right? And recent bleed is something, what are we talking about? It's just bloody stool from hemorrhoids or something more significant, so you want to look into that before making that the contraindication. Or a recent MI, that's another thing we violate all the time, because this is actually the patient that will stroke out most of the time. Bottom line of all this slide, you have to remember one thing. Do not let the exclusion criteria stopping you from calling the stroke team and activate the possible stroke treatment. Let somebody else make that call. Don't use this as a reason not to call. Okay? And of course, here you have your platelet numbers, your INR, but still, I would still not exclude anybody just because need some of these without talking to somebody else that actually is a little more experienced and does this on a regular basis.
For the recent MI, is like STEMI and STEMI intervened, was there any differentiation or just any MI?
It's a relative contraindication. If you have a STEMI and then you have a recovered EF of 65%, it's totally uncomplicated CAT. It's totally a block, and you've got an EF of 15% of null traumas. And so it really is contextual. These guidelines were created not only for the trial, but in an effort to allow nurse physicians in general practice to be able to decide DNA on TPA without backup. It's a little bit different when you get these complicated patients.
So you have an MI with an echo recently done that was normal, no thrombus or anything?
Yeah, no thrombus, no aneurysm, that's really what we often will worry about. I think that those of us on the stroke team would be a lot more likely to take a chance on that patient. And now that we have our options outside of just having TPA, these are patients that we usually take for intervention. So yeah.
I think the other concern too is bleeding after an MI, causing that in the person with TPA. And I think if you coordinate that particular intervention, all the more reason should so you should coordinate it. Something that can help you resolve that problem.
Our stroke team is probably the team that has violated more of these rules historically, but not because we or they are now cavalier. It's just because, again, we deal with complicated cases more and more often than other community places where stroke care is done a little differently. This is 1 second slide. You cannot leave this room without having seen this. We have TPA because this study was conducted here in Cincinnati in the 90s together with other centers, but we were definitely the lead center that showed that TPA works and saves lives. And this is the other 1 second slide to tell you the time is frame. As you all know, millions of neurons get die each minute that don't receive oxygen. I think it's 2 million. Is that your favorite number? 2 million, 20 million neurons? 2 million? Okay. So the sooner the better, and that's where you come into place to optimize that time. And then what if you get your TPA and then radiology calls you? I forgot to point that out. I need to go back to it because this has changed. If you can, when you order that CT, order a CT ad and neck, okay? Because things have changed. So this, I forgot to point it out, but remember that. And every time it's possible, the recommendation will be to order a head CT code stroke, which means that your radiologist will read the stat and call you, or they should call you if they see something concerning, versus going the pile of the other stat at CT that gets done at UC every day. And if possible, get a head CT angiogram of the head and neck, because we'll change what you do with that patient thereafter.
Why isn't this a part of post-stroke?
What?
The CT and
I'll get there. It is. It was not in 2013, because if you have this scan, what's wrong with this scan? What's happening to this patient? What's missing? Radiologist calling you and saying, hey, I know you know there is a stroke, but do you know that there is a vessel is completely occluded. Your left MCA is no longer perfusing this brain. There are great collaterals. There is a pretty stump there. So if you had this CTA angiogram in 2013, probably would have said, yeah, so what? Why were we even bothering getting the radiation and the contrast? There are 3 trials showing us that interventional, endovascular intervention with the hope of getting that vessel reopened showed really no benefits. One of the trials was, again, done here with IMS 3, and this is the time where I finished my fellowship, was a sad time where stroke care seems to stop. People were getting out of fellowship because there was no input to be a neurointerventionist at that point. But technology fortunately evolves. These were the devices that were used at that time. They were the corkscrew with the idea of going in, maybe with an aspiration device, get rid of that. That got replaced. Fortunately, the trials didn't stop, especially in Europe initially, with a little more sophisticated, I would say, device, stents retriever. And as those start being used in trials, this is where IMS was, but as Mr. Queen and other trials, SCAPE, SWIFT Prime, and another, there are several now, start coming out at the beginning of 2015, actually, endovascular change, results changed completely and showed, see this is IMS, the trial was quoting from Cincinnati, and showed no benefit from standard of care, okay, or not significant. It was actually altered prematurely because they knew that even if they finished the trial, the significance could not have been reached. All the other showed great 90 days mortality and improvement and MRS, so modified Rankin scale as far as functional outcome benefit. So things change, and now that it's 2016, to answer your question, you need a CTA, because if you see this, if you see a large vessel occlusion, the stroke team will change what they can offer to that patient and will send that patient directly from 6 South to Angel after the TPA has been infused. So this is the pool of those trials. I will highlight only a few of the category that matters to you that will, as far as criteria to include people for endovascular. So you give an ID TPA, who can go to IA to get a mechanical thrombectomy. All the trials were done with the good functional baseline, MRS is 0, 1 to 2, and that is still a condition that your neurointerventionalist will often ask you before putting somebody on the table. You need to document a large vessel occlusion. That's why that CTA head and neck is actually very helpful from the get-go and was not a couple of years ago. You did an aspect score greater than 6. This is a radiographic way for us to count a sign of early hypodensity. I'll say that the training is fairly complex if your eye is not used to it. And then onset to groin less than 6 hours, because all these trials had a, I don't see it here, but maximum to treatment allows the average around the 6 hours with some exceptions, okay? And now probably one of the hottest topic on the area, but still relevant to you because you're now following that patient to the angio suite and the angiographer is saying, the patient is moving, can you tube the patient and sedate it for me? What would you do, okay? Well, general anesthesia in some of those trials was applied in a minority of cases, and some of the retrospective analysis were done actually showed there was an increased mortality and worse outcome with those patients treated with general anesthesia. And I'm going to say now, don't ask me what general anesthesia meant, because we don't know for the anesthesiologist in the room, because none of the trial uses standardized approach of which drug, which level of anesthesia. We were just having this discussion in our journal club. Did they use gas? Did they use just TIVA, total intravenous anesthesias? So then that raised the question that allowed a couple of trials to come to be built. This is the last one that came out that compared conscious sedation versus general anesthesias, with the idea that there are some pro, right? Your angiographer, our angiographer is kind of split, but the idea is that if you tube the patient, you paralyze or you deeply sedate them, you have better imaging, you have that lead them to be more facile in reaching the vessel, so you have faster recanalization. It's safer in case of complication, because if you have a complication on the table, it gets a little complicated to get to the patient and get to the airways in a safely manner and prevents pain, so the patient is more comfortable. The cons, as you can all imagine, there are delays with the intubation. There's hypotension, which to me remains the biggest concern. There's hypercapnia that you can produce without knowing by setting the ventilator not correctly that can cause vasoconstriction and increase your stroke burden. The effect of the anesthetic itself, the delay in extubation once the patient reaches the ICU. This patient tends to have a longer length of stay. We don't know if there's a bias from the severity that is led by the severity of the stroke itself. A recent trial came out, find no difference between conscious sedation and general anesthesia in Europe. There are still some issues. The definition of general anesthesia, posterior circulation strokes were not tested. We don't know if the anesthesia was there or not, aka who is going to look at my hypercapnia or hypocapnia, who is going to look at my hypotension as the case gets going. That's not the OR. The angel suite most of the time is not in the OR. There is not an anesthesia crew available for these cases. And then what if the radiology calls you after that? Oh no, what if your angiographer tells you, hey, why my blood pressure is 200 now? What did you do? Did you stop the propofol? Did something happen? You just intubated the patient. And actually, the reason why the patient is now hypertensive is because they develop a bleed, and you can see the contrast coming out, and the blood going as they reperfuse the patient. There was either a vessel injury or this is a reperfusion consequence. There is some IVH, intraventricular hemorrhage. There's some contrast. There is some blood in the parenchyma. So what do? How do you reverse TPA? What do you do at this point? You treat the blood pressure, and then you reverse TPA. One point on the TPA effect that me and Courtney are very well aware of due to a recent patient together is that we like to say, and it's true, that TPA is very short-acting and cleaves the fibrinogen, the plasminogen, sorry, which activate the plasmin that get rid of the, that activate the fibrinolysis at the clot level. However, do not discount the fact that in truth, there is some systemic effect due to the fact that there is more plasmin activated and then goes into the systemic circulation. And you notice that because your fibrinogen levels are altered after, your systemic fibrinogen level can be altered after hours post-TPA, your INR can be elevated after TPA. So don't discount that when you look at your hemorrhage risk in the following hours post-TPA. Given this mechanism, how you reverse it, cryo is probably the more indicated as far as replacing the fibrinogen, how much you give it. You start, and then you check the fibrinogen level, and if you have the patient is actually hemorrhaging that you're trying to intervene upon, you correct them until the fibrinogen levels normalize. TXA has been used, FFP and platelets have been given. Platelets because most of these patients are on antiplatelets or giving an aspirin at some point, and also just to reverse any possible other effect on the heparin that was used during the procedure, for example. And then a neurosurgery consultation. These are devastating brain injuries, but I would not discount the possibility to have a surgical intervention in the right setting. So the mortality is super high, but I would still like you to go in this patient with the mindset where something, if there is something possible that could be done, you should be the one that tries. And then the malignant edema. The high risk for the younger patient, let's say that the patient did not get reperfused, right? So now is dealing with that stroke, the same stroke that the patient I show you, the second patient had an hemicraniectomy for. Younger patient at risk, if the left MCA was completely occluded, that is another higher, another factor that for development of malignant edema. It peaks at day 3 or 5. We've seen people at day 6. We've seen people at day 2. Don't use this as a fixed rule. Clinical observation matters. I would encourage all of you to use a pupillometer. It's relatively new, at least for me that train here, but to follow this patient clinically, it has been proven over the last few months that I've been using to be very helpful. Feel free to come and borrow us, ours, or I would say if there is a patient that you're worried that needs pupillometer, it's a patient that you want to ask us probably to transfer to our unit if all possible. What I'm trying to say with all of this, when the patient blows a pupil because of cerebral edema, it's too late. It's your job to do everything you can to see that moment coming and be ready. And by ready, I mean as far as the medical management, hyperosmolar therapy is a good bridging therapy, so you have to be ready for that. We're not going to go in the mannitol versus hypertonic. We all know that hypertonic is pharmacologically cleaner because it doesn't as a diffusion coefficient of 1, so has less capacity to go in the healthy brain to stay, remains in the vessels instead of entering the parenchyma, a little bit better than mannitol that has 0.9, so there's all the theoretical concern about mannitol actually going into the dead tissue and increasing the edema. Time matters here. If you have a PID, I tell all my fellows, get the mannitol going and get your central line for your hyperosmolar therapy. On the other hand, if you're ready to go, 23.4% is the highest concentration, smallest volume that we have available here. You need pharmacy, so you have to have it at the bedside. For any of these patients, those medications should be at the bedside. And then, last but not least, and this is the last slide on stroke before I give you time for the question. The hemicraniectomy, you know the story. There were 3 trials between 2006 and 2009, I believe. France and Europe and Germany, they all proved that early hemicraniectomy to avoid saves lives and improves outcome. And you see this bar that's been shown many times where you're actually increasing the people that had an MRS of 3 and 2. So you improve quality of life somewhat, but definitely save lives. Okay, and that's how that needs to be presented. There is a UCMC protocol. I would not use that as an exclusion criteria for not calling neurosurgery. You should have clear in mind that you should call them for any case where you suspect malignant edema. I am adding a MCA stroke here, but cerebellar stroke apply the same rules. We know that early is the best, and sometimes I've used an early MRI to show the degree of stroke before the head CT can prove it or before that pupil blows, to do it in a prophylactic way. Neurosurgery likes that, so it's never too early. And then consider age and functional status. There have been reports where people in the, from Japan, I think, where there were a series of people in the 80s that benefit from hemicraniectomy. I'm not saying that that's the age is excluded by our protocol. Our protocol, I think, goes up to 60 or 65, but I would not stop you from calling because the patient is 79 and was golfing the day before and has now a right MCA stroke that could be well, they could be decompressed at this point. I think that's it. I made it into an hour. Oh, a little more than an hour. Any questions? Yeah.
This whole cerebral edema seems similar to me to one of the fears after crowd and to me with hyperperfusion syndrome. Yeah. I know that a lot of vascular surgeons, in my experience, they're kind of treating that. Obviously, it's chronic occlusion versus acute occlusion, but is rigorous blood pressure control and keeping blood pressure low to decrease the edema hyperperfusion syndrome. Is there any guideline for what blood pressure should be after this, or is anyone looked at decreasing edema by lowering blood pressure?
Yeah, so I'm just going to repeat for the people that are listening. Dr. Jones was asking, what's your blood pressure target after decompression to prevent reperfusion edema, correct? Or even during the early edema phase? Is
yeah,
that the idea?
Before, to try to avoid getting them to have to be decompressed, but when they're actually doing the clot retrieval, post-clot retrieval, what should their blood pressure be?
Right. So, is there any blood pressure goal to during the early phase to avoid the reperfusion edema? Okay. So you have there's one thing to keep in mind that you have two different. You might have different goals there because you want to maintain perfusion because you don't know what's happening to the penumbra. If you're doing an acute procedure, you know there could be some tissue that is salvageable as you open that is currently fed by other vessels. So in the superacute territory, as long as you don't, the TPA guidelines is less than 200. So you stay there in the acute phase, okay, both IA and IAB. When it comes to the post-hemicraniectomy, the surgeon will ask you to be less than 160 for the first 24 hours. So once the skull is being opened up, that is their goal. But as far as reperfusion injury during the procedure, you still have competing interested also from an ICP standpoint, because if there is edema and you decrease the pressure, that might actually hurt you that way. So the 200 is still, the less than 200 is still the goal for any acute intervention. Different cases might have different answers. If you have clot or if you're worried that the vessel was not open completely, that's where we go all the way to PRESS patients that show post-intervention to be still pressure dependent because maybe the intervention was not successful, or despite the intervention, they're still living out of weak collaterals, but there's no fixed guideline as far as acute stroke care. Would you add anything? Yeah.
Well, I think the main difference is where you're at in your autoregulatory curve. So the problem with the difference is this tumoral edema from infarct is related to or causes loss of autoregulation of the lower arm of your autoregulatory curve. Whereas reperfusion or atomic occlusion, when you suddenly have enough necrotic, it's the opposite. It's the upper limb of the autoregulatory curve. And so the treatment is of differing parts of the time. So once you decompress these folks, you tend to just target or before you decompress, and just have to look at these no target or CP, like we learn folks who have cerebral maps and God.
Okay, thank you.